Welcome to St. Charles 2026 Fall Education, a risk assessment and prevention intervention for nursing. So looking at the fall risk assessment and the fall prevention policy, looking at the first part, which would be the assessment, know that we do a Morse fall risk and a fall predictive analytic tool. Inpatient observation, including BHI, will be assessed according to these two policies. When we are first looking at it, know that the Morse fall risk is what we do on the initial assessment. And so that number, that score, is used for the first 12 hours of admission. It's important to know that the fall predictive analytic tool or the PA tool only comes into effect after 12 hours because it pulls data from the EPIC chart, like labs, vital signs, other information in their medications, and that pulls in, and that's what creates the score. So it doesn't have enough information in there to give you an accurate score until 12 hours. So again, Morse fall risk will be completed on admission, and we will use those interventions. At 12 hours, we will now go to the PA fall risk. The PA fall risk recalculates a score every 4 hours, so it may change throughout their stay. It is important to know that once you are a high fall risk for the PA fall risk score, you are a high for the next 24 hours. So on admission, making sure that we communicate with our patients and explain why they're a high fall risk, what we're doing, and the reason behind that is going to be key to getting them to understand and be really accepting of what we're doing to keep them safe. So some examples are explain why a patient would have a higher fall risk on admission or in the hospital. So the fact that they have medications, it's a different environment, there's tubes and lines connected to them. It helps them understand why we are doing some of the things that we do. Give examples of commonly used fall prevention methods. So stay with me and bed alarms. Tell the patient their current fall risk and explain to them that this is going to change throughout their stay based on vital signs assessment, lab results, and more. Describe a bedside shift report. You will be told what your fall risk is, and we will tell you what we're using for preventions. Script your verbiage when we are using the bed alarm to help them feel a little more in control. So an example would be, we use a bed alarm for your safety to help us respond to prevent falls or injuries. We understand this can feel limiting, but please know that this is a temporary measure to protect your well-being. Thank you for understanding. Another example would be, I will stay just outside your bathroom door while you are in there and keep it cracked so I can immediately respond to you. Some additional scripting would be, it is important that you ambulate even though you don't feel your greatest. Since you're at a higher risk for falls while in the hospital, we will keep a gait belt in your room and use it anytime you get up to help support you and have a way to help you to the chair if you become weak or dizzy. It's never okay to just tell the patient, I have to do this because my policy says, or I have to do this because my manager says. Explain the why we're doing these things and just make sure we're doing it in a kind and respectful manner. So looking at the fall risk assessment or the PA fall risk, there's a few places you can see this. If you still use a patient list from EPIC, you can view the whole unit from that one and it'll tell all your high risk fall risk on there. If you hover over the number, you can see it kind of digs down into what is making this patient a high fall risk. The high fall risk score low is 0 to 34.9, moderate is 35 to 49.9, and high risk is 50 and greater. So additional ways to look at the PA fall risk and for documentation, use the Shift tab to the Med-Surg folder to document and review your PA fall risk. You are to do this every shift. You can also review and confirm the PA fall score from the BPA that fires if your patient's a high fall risk by clicking review, or from the screen that you see here up in the right-hand corner as marked review. If you want to review the fall score history, you can go into the flow sheets under the EPIC predictive tools, and you're able to see the fall risk today and then prior ones. If you don't have that in there, all you have to do is go to that little caret, search it, and then add it to your header. Fall risk assessment overriding to make a patient a high fall risk. Occasionally, you will find that a patient may be a low or moderate fall risk based on the PA fall risk, but actually, per nursing judgment, is high fall risk. Examples of this may be a patient with an amputation or a patient that has fallen in the hospital. So in order to override that and make them a high fall risk, under the fall risk interventions, there's a title, a nursing judgment fall risk high. Just go under that and type in yes, and that will add the high risk header to the patient. Now, it does not change the PA fall risk, just so we're aware, but you are able to override to make the patient a high fall risk. All right, looking at the fall risk preventions per policy, there's a few different categories. One of them is our standard fall risk prevention. This is for all patients that come into the hospital. It is not an all-inclusive list, but here are some areas it wanted us to touch on. So orient your patient to the environment, making sure they know where the bathroom is, making sure that we keep the pathway clears, so no poles in the way, no plugs in the way, keeping clutter off the floor itself. Using the call light, making sure it's within reach. Intentional rounding, so purposeful hourly rounding, keeping your bed low, keeping the bedside commode within, a safe distance from the bed, the urinal, and then intentionally toileting. Also, it tells us to reinforce activities like handrail usage to the patient and families, and the non-slip footwear. Looking at the moderate fall risk, some interventions include the yellow band, using the Stay With Me program on a mission, and then reinforcing that with them. And then post the fall risk signage on the door or the light system. Looking at the high fall risk, so in addition to the standard and moderate interventions, we are going to add a fall risk band yellow. Use the visible signage. A fall risk banner is displayed in the EHR. Use of bed and chair alarm. Consider moving the patient closer to the nurse's station, using a fall mat, keep the bed low. Telesitters, if we think that would help. Remember, telesitters are never appropriate for suicidal, homicidal, or behavioral health patients. Safety companions, if we are unable to redirect with the telesitter. We can have a falls agreement with the patient, increase rounding, and ask family to assist with increased observation with the patient. In addition to these fall risk interventions, all patients, we should ask them what assistive devices they use. So Walker, Saracetti. We should be using a gait belt for ambulation. Use of a second caregiver for ambulation if the patient's weak, or really if there's a large size difference. So if I'm moving somebody that is substantially larger than I am, I might want to grab another set of hands just to keep them safe and myself safe. Intentional toileting, so prioritizing the potty when you hourly round. Other additional considerations would include yellow fall socks, stay with me for all moderate and high patients in the bathroom, stay with the patient when they're out of the bed, keep an eyes on the patient, and stay within arm's length. Documentation, intervention should be documented at least once per shift. If a patient falls, changes level of care, receive medication that affects the mentation, the fall risk should be reevaluated and interventions reconsidered and documented on. So if we have a low fall risk and for whatever reason they change it to a high fall risk during our shift, we need to make sure that our documentation and our interventions reflect that. Refusal policy, an informed refusal. If a patient refuses any fall risk interventions, follow the policy details and utilize the refusal form for the MedX. So the policy says each patient can refuse any interventions and following actions should be taken. So educate the patient on the fall risk score and prevention, re-educate as needed, engage the patient's family in the fall prevention and interventions discussed, escalate the patient's refusal to the nursing leader or designate for assistance, escalate the patient's refusal to the provider, and if applicable, patient should sign the refusal form. See documentation selection for further guidelines. So that's what the policy says. And I think all of us have seen the refusal form. But if they refuse once, we should all, keep educating them, keep talking to them about it. And then hopefully we can get them to adhere during their stay. So a new process we're starting is during bedside handoff. We're going to put a bed alarm notice. So if you look at this picture attached, there is a red band that's placed on the bottom of the bed. The red band is to be utilized on high fall risk patients. This way, it is alert staff members while they're in the room that the patient's a high fall risk, also that the bed alarm should be on. So patients with a high risk of falling, the intervention should be discussed during bedside shift report for every patient. This should be the current most accurate PA fall risk. So 4 and 4 would be the easiest way if you're working a 12-hour shift. So 4 a.m., the night nurse will review that and then discuss it with the day nurse during their bedside shift report and include the patient. So their fall risk this morning was, a high fall risk. I have my band on and here's the interventions we're using. The PA fall score and the DI score will be added to the Epic handoff and call out actually to the progressive team because they are the ones that brought this up. So you should be able to see it on your handoff. It'll give your most current PA fall risk and the DI score in that handoff page. So using the gait belt, we have a quick video just to kind of go over how we use that and just how to instruct the patient. So go ahead and take a look at this.
Come in.
Hi, Miss Shirley. How are ya?
Oh, I'm doing good. I have to use the restroom. I'm glad you're here.
Perfect. I'm Brittany. I'm the physical therapist. I'm just going to turn off your bed alarm.
Okay.
And then I'll get your gait belt and your walker.
Oh, okay.
And then I'm going to have you sit on the edge of the bed. Do you need any help?
No, I think I'm okay.
Let me uncover you here so we get that. We don't want to trip.
I don't think I need a walker.
So according to your board, yesterday with therapy, you were doing a moderate assistive one with a walker. So I just want to see, I know they did some medication adjustment, so just want to make sure that your blood pressures and things like that, you're not feeling any lightheadedness. So moderate assistive one is I'm doing 50% of the work and you're doing 50% of the work.
Okay.
If it's different than yesterday, then I'm going to update it before I leave.
Okay.
So gait belt, we put this on every patient. It goes around you near your belly button.
Okay.
Lift your arms just slightly for me, please. You don't have any incisions, right? Okay. So you're going to go through the teeth. You're going to get nice and snug here. But make sure they can still breathe. And I might have to adjust it when we stand. Do you have a weaker side?
I don't think so.
Okay, if you did, I would stand on your weaker side, but I'm going to just stand on the right side for today. You got your grip socks and your feet flat.
Yep, I've got my grip socks on.
I'm going to stand here with the gait belt kind of holding on the back. Can you put one hand at least on the bar here if you want to push up from where you're coming from, okay?
Okay.
All right, let's stand together. Push through those legs, stand nice and tall. Hand on the walker. Are you
Okay.
dizzy or anything?
No, I feel okay.
Okay, so we're going to walk to the bathroom, and as we walk, I'm going to grab this chair here. So come with me a little bit this way, just so I can grab this chair. Now we're going to turn and go towards the bathroom.
Okay.
I'm going to keep it close, just because you haven't been up in a day. Never know how you're feeling.
I feel kind of dizzy.
Okay, I got the chair right behind you. Let's stop. Reach back. Reach back for the armrest here. Good. Slowly lower yourself into the chair. We're going to take a rest break. I'm going to call your nurse and get a blood pressure, okay? But are you...
All right, so that was just a quick demonstration of how to put the gait belt on, kind of how you communicate with the patient and just how to use the walker. And then next area, we're going to talk about keeping the bed plugged in and how to make sure that the bed alarms are coming to the call light system.
So in order to properly ensure that your bed alarm goes to the whole call system, you need to make sure that you have this cord that attaches to the bed. These should remain attached to the bed. They screw in there, this little thing. And then into the wall, you need to have that plug, and these go together like this. And then if that goes through, in order to make sure that it is working, you can always test on the red button on the side of the bed. If you hit it, the call light should engage and show that the call light is on, in the case of, to make sure it's going through the whole call system, so it's not just ringing for the bed. And then we'll also at that point make sure that we turn this system on over here. So use the status and do the bed exit set and high fall risk if that's applicable, or fall risk.
All right. Looking for therapy levels of assist. I'm going to give you a moment just to kind of review what is on the screen. If anytime you have any questions about what physical therapy or OT puts on the board, they will gladly help walk through what those means. Okay, just looking at some actual data on falls, we pulled up some falls from last year for progressive and just time frame and then some of the reasons. So for progressive, we found that there was a fall for bed alarm refusal. We had a couple lowered to the ground with a gate belt on and a couple lowered to the ground without a gate belt on. So definitely in the ambulation, and that's kind of where the 2 assist will help with some of those. So if it's someone, like I said, someone that we wouldn't really be able to safely assist to the bathroom, maybe grabbing that second set of hand. And then the bed alarms going off, no bed alarms. So 6 of our falls were no bed alarms. 7 of our falls, we did not follow the physical therapy guidelines. And then 8 of our falls was the no stay with me in the bathroom. We did see a lot of falls during that shift change too, so which is not really too surprising. You know, that's a very busy time for our patients. So looking at Med-C, they had 11 of their falls was with the bed alarm sounding. They had also some lower to the ground with gate belt, without gate belt, 8 of those. Some stay with me is not utilized. A couple of them were bed alarm refusals. They did have some family dynamics as well. I just thought it's a nice breakdown of what is happening and when they're happening. And there's broke down between days and nights as well. So what to do if your patient falls? First thing you're going to do is make sure you take care of the patient. So assess them, do a neurological, quick assessment, check for injuries, get some vital signs, ensure that the patient is safe. So after we have done that, make some notification. If the patient is not awake or has hit their head, you'll want to call rapid response. So notify the house supervisor, and they will do a fall debriefing, notify the provider, notify the family. Along with that, we should be documenting in the chart what happened, who was present, vital signs, quick assessment, who was notified, and if we received any orders. So if they ordered an X-ray or CT, that should be in our progress note. Make sure that you do notify the house supervisor, manager, if there is any testing that resulted. So if you had a patient fall, we got an X-ray and it came back, 6 hours later that the patient has a fracture, please make sure that we're notifying the proper individuals. And then enter the safe care. Thank you so much for listening to this education. Feel free to reach out if you have any questions or if you need any additional information. This will be mandatory information. So in the email provided to you, you can click on the link as seen here on this screen to attest that you reviewed this, or you may scan the QR code to attest that you watched this video. All right, thank you and have a good day.